Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record so that you get credit for being here, and also please remember to fill out the program evaluation and give us any ideas that you might have in regards to future topics and future speakers. Today it's my pleasure to introduce Dr. Ricardo Arbulu. Dr. Arbulu is board certified in internal medicine and also infectious disease. He did his postgraduate training at Henry Ford and at the University of Illinois in Chicago, and he is the Department of Infectious Disease at McFarland Clinic. He's here today to discuss the returning ill intercontinental traveler, and please join me in welcoming Dr. Bulu.
Thank you. Thank you very much. How's this mic working? Good? Great. Well, I have to thank the very motivated audience who came on the middle of a snowstorm in Iowa to hear about dengue, malaria, and tropical diarrheas. Jokes apart, my first objective is to show with numbers that that's an important burden of disease, and primary care physicians need to know about it in the United States. There's a lot of people getting sick with the diseases I mentioned. Practically, we want to be familiar with the resources that are available to provide optimal pre- and post-travel care as well. So let me show you some numbers. In 2007, over 60 million U.S. residents engaged in international travel. That's a lot. You can see there's a trend since 2004 to 2007 of both increased total international travel, but also overseas travel. In fact, that's what's driving the increase in overall travel. There's a constant travel to Mexico, which, as you know, carries a risk for certain travel-related infections. So conclusion from this slide, a lot of travel, and looks like it's rather increasing. So these people, let's make a very conservative estimate. So we said 60 million people traveled abroad, subtracting those who traveled to Canada that we know of. So 10 to 30 million people, and this is very conservative, would travel to the tropics or the subtropics, and that are sort of overlapping with countries with low or middle income. And so we come up with 10 to 30 million people that are at high risk for traveler's diarrhea. This is a disease that has a very predictable attack rate, so we know that a third of people going to these countries will get traveler's diarrhea. And they're going to areas where malaria occurs really at a raging rate. I have gathered that people are not very familiar with dengue, but we're going to beat dengue to death. This is the most important pandemic at this point as far as mosquito-borne disease. So, given that risk, I mean, you would expect that people seek care before travel, but it turns out that less than 50% do. And this comes from some diligent group that studied people coming out of Boston Logan International Airport and found out that by surveying them that, well, less than 50% had sought advice. Whenever there's an acronym in medicine, you want to be interested in things. So here's an acronym for you, VFRs. So I am a VFR. I'm an immigrant who eventually will go back to visit friends and relatives, including, and that this demographic includes US-born children and a spouse of these people. So when I go back to Peru, I am a VFR. By being a VFR, I am more likely to be ill. I am less likely to seek pretrial advice from Dr. Jugelon or Dr. Wolf, and more likely to engage in eating ceviche in the streets. And these are not things that I just made up. There's a long list of these considerations in the Yellow Book, which is kind of the CDC resource for travel. Please keep in mind the VFRs, we will refer to them later, and they are in part why this topic of travel, this topic of travel is gaining more interest in recent years. So let's take now people who do come ill. And let's look at data. This is not only from the United States, but from all the developing world. And we have a fair amount of patients that have been investigated in this GeoSentinel surveillance network, 17,000. So among the ones who do seek care, please note that this is different from the ones who actually are ill, because some of them may not seek care at all. If you single out one cause, well, they come in for fever, but if you pull acute and chronic diarrhea, that beats fever. So it's consistent with what we showed you before. There's a lot of diarrhea going on. Fever is up there. Skin disorders are next. Respiratory illness is not that big in returning travelers. I think that's a strong point to make. And let's not forget that people do have sex abroad. They do get involved in car accidents. They are less likely to wear, that's actually a fact, they are less likely to wear a belt when they ride a car. They're more excited to do things, so they get in trouble, and that's 19.2%. So let's speak about these people who return with fever. This is by no means a comprehensive list, but the point I'm trying to make here is bring to your attention kind of the priorities of diagnosis according to the place that people travel to. So malaria, number one, hands down, returning from sub-Saharan Africa. And from all other regions in the tropics and subtropics like Southeast Asia, South America, Central America, it is top 3. Dengue, again, we're going to come back to this. It is number 1. So, I mean, people who are not familiar with the dengue pandemic would find this surprising, but it's number 1 in all the regions I mentioned outside sub-Saharan Africa, like Southeast Asia, hands down, in Central America as well. Rickettsial disease, and this, I mean, I'm acquainted with African tick-borne fever by virtue of my infectious diseases training, but I really was surprised to find in multiple references that indeed this is number 2, only to malaria, in sub-Saharan Africa. And I bet, I'm not sure if people have seen that before, but it's really important apparently. And then we have enteric fever that you got to think about that when people come back from the Indian subcontinent. It is cosmopolitan. You can get enteric fever. That's another term for typhoid fever that I would prefer because it can also be caused by paratyphoid, so it's not technically typhoid fever. You can get that in the US. Unlike malaria, we will talk about dengue, some interesting transmission in the United States going on. But my point is enteric fever is big in the Indian subcontinent. Very important in this list is Katayama fever, acute schistosomiasis. This has a buzzword, okay? So if somebody tells you they've been wading or swimming in fresh water in Africa, you got to think about it. It's all this that we're mentioning here, these are all febrile illnesses, okay? So the patient can come to you with a flu, quote unquote, right? So, and nothing else. Some of them have rashes associated that we're going to show later, but for the most part, they can come with you, or they will come to seek attention just with a flu-like illness and some fever. Leptospirosis is relatively infrequent, but the buzzword and the association is so strong that you really want to commit that to memory. If somebody tells you they've been canoeing and rafting pretty much everywhere, it's cosmopolitan, and they are sick, you got to think about leptospirosis. And let's not forget that people can get still pneumonia, UTIs, boring strep pharyngitis, influenza, acute retroviral syndrome from HIV. That's important. They're more likely to engage in sex when they're traveling. So without further ado, let's talk about malaria. Just a refresher slide for some and slide to quickly situate us for others. So there are 5, not 4, but 5 species of Plasmodium that cause malaria. This might be news for some that there's a Plasmodium novelsi that has been documented. It used to be a simian Plasmodium, and it has been documented to have human cases in Malaysia. None in the US yet. So what you really care about from the practical point of view is Plasmodium falciparum. Think this is the big and bad. So it makes up 2/3 of the causes imported to the US, and this is the one that most likely causes severe malaria. The others are always, we see a little bit of that every year, Plasmodium vivax and Plasmodium ovale. These are your relapsing forms. And we will talk about relapses later, but these are the ones that have the capacity to generate these cells called hypnozoites, hypno for sleep. So they remain in the liver for years and they can reactivate later. Finally, we have Plasmodium malariae, which is very infrequent in the United States. So again, Plasmodium falciparum is what we care about, big and bad. Then we have the relapsing forms, and then Plasmodium malariae, which if you got that, you're really lucky. We do not have Plasmodium noelsi in the United States yet. And it's not anticipated. It's very, very regional to Malaysia at this point. So this is a parasite, but you get the disease by being bitten by a mosquito, which is a female Anopheles mosquito. And this mosquito bite specifically at night, from dusk to dawn, okay? There is no vaccine for malaria, in case you wondered, and you can get reinfected. We talk about immunity. You will hear, probably I'll say this later, immunity against malaria. When we talk people that are immune and no immune, what we are referring to is basically people that have had malaria before. That doesn't preclude you from getting it again, but you do generate some immune response that prevents you from having or make you less likely to have severe disease. That explains a little bit why small children and pregnant ladies are more likely, well, pregnant ladies not so much, doesn't follow the logic, but small children, as an example, in endemic areas, they don't have the immunity yet. They haven't had enough malaria as adults have. People have malaria over and over in endemic countries. So these kids get the worst part. They can get severe malaria. Pregnant ladies, since I mentioned that, they are also a very vulnerable population. They get sicker, they are more likely to get severe malaria. So this is where malaria is found in the world. I hope the colors show well. This kind of tan color reflects the main areas, the malaria transmission areas. So sub-Saharan Africa, big time. Southeast Asia, in parts of the Americas. This includes Mexico as well. The reason why this is in green is because this picture also shows you the areas that are chloroquine sensitive malaria, which we're going to come back to. But basically, malaria is found in Mexico, is found in the Caribbean and Central America. And as you see, not in all South America. Another point to make here, thanks to this picture, is that, well, this is my country, Peru. It's not sufficient to say, well, I'm going to visit Peru, and you'll get your pre-travel consultation that way. It's really specific to areas, as you see. I mean, there are areas in Peru that have malaria that most people do not visit when they go. This shaded area is the Amazon. That's where you get malaria. But if you go to visit my parents in Lima, there's no malaria there, period. So there's other areas with limited malaria transmission, but let me make this point here. So it's essentially the tropics and the subtropics, and you will see this over and over. This map will be repeated over and over, very similar to the dengue one. So if you make these lines in your mind, the Tropic of Cancer, the Tropic of Capricorn, that's the tropics. A little bit on top of that somewhere, but if you want to remember, it's the tropics essentially. So this makes 2 points. First, where are these people getting malaria? Where are these U.S. residents catching their malaria? Most of them are returning from Africa. And if you factor in that most people don't go to Africa but to other places, you realize that the risk of going to sub-Saharan Africa and getting malaria is enormous. And I see people getting excited because there are frequent travelers to Africa here, right? So we are disproportionately affected by malaria in this clinic and hospital. A bit of that comes from Asia. Less comes from the Central America. That's what this abbreviation means, and the Caribbean. And see, South America is really small. Everything else is almost anecdotal. So Africa, and we're talking sub-Saharan Africa, not Libya or the places in Africa that recently had all these revolutions going on. The other point that this slide makes is, well, how many of these people are U.S. residents and how many are foreign? So visitors coming in, and this statistic includes recent immigrants, okay? So, well, there's much more returning U.S. residents overall than foreign people coming in, but still they make a significant amount, right? And I'm sorry, one point that I wanted to make here too is that it's not shown in the picture, but these U.S. residents, if you break it down, they are mostly, or not mostly, but 30% of them, which is disproportionate for the total number, they are VFRs, like me. So just to drive home again, the VFRs are at great risk. Now let's break it down by purpose of travel. And again, this makes that point much better. If you're visiting friends and relatives, BFRs, again, sorry, big part of the problem. These are all the cases for malaria. I mean, a lot of them are going to be some resident, some foreign-born person who is now a resident and is going to visit back their family. We don't have that many missionaries or dependents of missionaries if you look at total numbers. So these guys are disproportionately affected. I mean, 7%, that's a lot for the little amount of people who are actually missionaries. And then, well, the business people, the tourists, and so on, they get a little share of it. The main point of this slides, again, the VFRs, that we need to capture in our clinics because they are less likely to seek pre-travel consultation formally. Part of one of the reasons they list in the yellow book is, well, it's cultural. People from South America are not very anticipative. We don't like to plan ahead. So chemoprophylaxis taken. Okay, so people may be wondering, okay, these cases I hope occurred in people who were not taking their medications, right? I think I need to correct this number. This doesn't sound right. Please, this 25% is not right. I typed that in and it's evidently wrong. I think I meant 75%. These are absolute numbers of a sample of 898 people. And the vast majority of them, I think it was 75%, sorry about the typo, are people who are not taking their prophylaxis. So we are reassured about that. However, there's other people who were just taking non-CDC recommended drugs, that they were taking the CDC recommended drugs, but they were partially compliant. And finally, this purple segment, 7% of people were doing everything right, or supposedly doing everything right, yet they got malaria. And those are going to be those who are just unlucky to get malaria that is resistant to what they were taking. So where are these cases in the United States? The vast majority, so first of all, every year we get approximately 1,500 cases of malaria in the whole United States, and that's a constant number since the 2000s, and recently it has been increasing, slightly since 2008. So this is the last date I have this complete graph for you, and this is in 2010. So among these 1,691 people, you can see 8 were in Iowa, but most of them are concentrated in New York City, well, reflecting where they come from, California, Texas, right? So it reflects that this is an imported disease. Last data that is not here from the Iowa Department of Public Health, we got 14 in 2011 and 22 cases in 2012. So you can say it's in the rise. So what are the manifestations for malaria? I don't mean to make a huge lecture out of this, but some things we ought to know. The most important thing when considering the differential diagnosis of fever in a returning traveler is this incubation period, the time from where they could have been possibly beaten until the time they develop the disease. So the CDC is giving us a very cautious time frame to consider of 7 days to 1 month, while in reality most of these infections occur a little over after a week in up to 2 weeks. So when you see somebody beyond that, your suspicion should decrease a little bit. So let's talk about uncomplicated malaria. If you see somebody like that, you are probably reassured that this is uncomplicated malaria that is going to be 0.1% mortality rate if you treat them appropriately. So fever, as we said, a nonspecific syndrome, right? But specifically fever up to 40, this tends to be high-grade fever. The periodic fever that we learned in medical school is no longer true. I'm not sure if it was ever true, significant, these things get described, everybody gets excited, and it's there. In fact, when it occurs, the diagnosis is almost certain. But if it's not there, don't say it's not malaria. It's still very likely to be malaria if you come from sub-Saharan Africa and you are within this time frame. So it's all about where you came from, what's the time frame, and basically that's what you have to rule in your diagnosis. Okay, as primary care physicians, you want to rule in a potentially severe disease like this. So notably, malaria does not have a rash like some of the other diseases that we're briefly going to talk about. But you do get hepatosplenomegaly that children get most, and jaundice. Jaundice is very frequent in adults. Now, severe malaria. For the previous slide, you call your medical student, you show them, you're happy, but for this, you call Dr. Carlson or the hospitalist and put them in the ICU. So severe falciparum malaria, okay, it's essentially, it looks like sepsis, like septic shock with some particular hallmarks. Cerebral malaria manifests as coma, convulsions as well, but the coma persisting 30 minutes after convulsion. So they are not in postictal, they are obtunded from the malaria itself. And everything else, as I said, it looks like severe sepsis progressing to septic shock, like acidemia, severe, this one is particularly bad in malaria, severe normochromic normocytic anemia, which to qualify for severe malaria is less than 5 grams per deciliter. And the reason for that, as we're going to show in a slide, malaria destroys your red blood cells, essentially. That's what the disease is. Acute kidney injury, hypotension, of note, hypoglycemia. So if you are to take some of these major hallmarks to remember is the obtundation, the mental status changes, the convulsions, and the hypoglycemia. Other criteria, if you wish, minor criteria, this hemoglobinuria, which may be seen in patients who have uncomplicated, non-severe malaria. So it by itself is not a reason to get excited, but if you get more than one of these, certainly you want to start worrying about the patient and admit them. So impaired consciousness, frustration, excessive debility, and this is an important one, and it stresses the fact why we need to get a smear. Hyperparasitemia. In non-immune, here's the little word again, non-immune, meaning patients who are having this for the first time. Or in any patient, parasites more than 20%, that's a reason to call it severe malaria. And what I mean is, you look at the smear, you section it, and if the whole area is 100%, 5% has parasites, that's severe malaria. This woman is extremely happy because she's so not getting malaria. They make it pretty ridiculous in the CDC with this picture. They only missed the time of the day. I think she's kind of preparing for the night and stuff. But basically, she's got the long sleeve shirt, check. She's got all the DEET-based products. And I always forget, Dr. Jugolan, you remember the actual name of DEET? It's really, it's one long compound, but it's DEET. It's a molecule that it's used in air sprays. I mean, not any air spray is good. The ones that have DEET have proven to be good. Similarly, DEET-based repellents. And finally, chemoprophylaxis, so the drugs we can give. Did I mention, well, major miss here, that I think it didn't make it to the slide, but look at this net. This is the major way she's protecting herself later in the night from malaria. We said it doesn't bite during the day, right? And this is from the CDC. Okay, I don't want to make this dry, but we kind of need to go over the drugs. Okay, we may need to come back to this one to move on, but essentially I want to show you the drugs that are available for oral treatment of malaria. We have chloroquine and hydroxychloroquine, mefloquine. They are all quinine derivatives. And we have then atovaquone proguanil, which may not be familiar to some people who haven't seen this in a while, brand name Malarone, which patients may confuse with mefloquine, right? And then doxycycline, plain old doxycycline that we use for bacterial infections, treats malaria and helps with prophylaxis, and primaquine. So a few remarks. Actually, let me go over the whole thing. So chloroquine, as I showed you on a picture before, let me just go back. It is good news to be still susceptible to chloroquine. As you see, most areas in the world are not susceptible to chloroquine, okay? So some notorious areas that are still susceptible to chloroquine, which has been around since 1945, are the Caribbean and Central America. So anything north of the Panama Canal. That's how you think about it. There's no resistant malaria there, so it's safe to use it, and we prefer to use it. And as you see, elsewhere is some scattered spots in Asia and even in South America. So it's big news to be still susceptible to chloroquine. We prefer it when we can give it then. Please note that this drug and the very similar drug, hydroxychloroquine, is dosed weekly. So picture if you are going into a trip, you have to anticipate and start taking it weekly. It needs to be taken 2 weeks before. So, I mean, that's a lot of anticipation for some travelers. Mefloquine is infamous for the neuropsychiatric side effects that have been exacerbated by the media. I have seen a patient who came back from Africa, and she had a neurologic disorder that I couldn't remember. I couldn't pull back her record, but she had a neurologic disorder to start with. And she came in with complete imbalance, and she was falling down. We took away her mefloquine, and she improved. So that's real, but it's rare still. Since the 1990s, there's some resistance to mefloquine in Southeast Asia. So Myanmar, or also known as Burma, the Thai-Cambodian border, and Marshalltown. We get a lot of people. If people are not acquainted with that, we get a lot of people from Burma who are refugees. So refugees, like any new immigrant, get the same epidemiology as local people. Anyway, we got to move on. I wanted to show this. That solves a frequently asked question. Why do I need to take my prophylaxis after the trip, right? So what we are doing with these drugs, please let me just break this down for you. So we're seeing two things here. Parasite, or the mosquito bites you, and then the forms go straight to the liver, okay? They need to mature in the liver in these forms called schizonts, and then they are released to the blood. You do not feel this asymptomatic phase, which is actually the incubation phase. And what you feel is actually, well, when the parasites are released to your blood and they start infecting your red blood cells and they destroy them. That's what the disease of malaria is. So these schizonts are the first pass. And in these relapsing forms, the Plasmodium ovale and the Plasmodium vivax, there is a little additional kink to this. So the initial infecting parasites can go to schizons and mature right away, or right away I mean in a week or 10 days as we said, or they may decide to become hypnozoites, which basically hibernate in your liver, and they can reactivate months or years later, causing the relapses of malaria. So, okay, so back to the question. Why do I need to take the drug after my treatment? I think I accidentally kicked it off. Can you hear me still? Because, okay, here it is. We got it. All right, where were we? The reason is most of our drugs, except for a couple of them, only kill the blood forms. So what you're doing with this prophylaxis is actually treating malaria if you get infected. So, I mean, you get it, it goes to your liver, it matures, then it's released to the blood, and only then we kill it with malarone, doxycycline, mefloquine, or chloroquine. So these schizons kind of lay back a little bit, or lag behind a little bit. So when you come, you still have forms released to your blood. So you got to take it after to kill those forms that are being released, okay? So the only drug that actually kills the schizons as well, the only two drugs are malarone and primaquine. So that's why when you're done with your trip, next slide, or previous slide actually, there's a difference between how long after your trip you take them. In most of the cases, you need to take it for 4 weeks to continue killing all these forms released to your blood. But in the case of atovaquone progranulin, malarone, and primaquine, you can just take it a week and you will kill all the schizons by doing so. Probably that got a little bit complicated, but that's a frequently asked question of the patient. You can simplify by saying, well, you need to treat ongoing malaria if you wish. I mean, it's still being released to your blood if it's there, so you cannot afford to end early. And as you have noticed in the previous, okay, going backwards. As you may have noticed, they all have different schedules, okay? Before the trip, we take it, the hint is you take it 2 doses, okay? The people are really confused about, some 2 weeks, 2 days. It's essentially 2 doses. We want to test tolerance and we want to get good levels of the drug before your trip. Mefloquine is the one exception. It's recommended to start 2 weeks prior. Okay, let's move on. I'll leave this slide for the people who have more intellectual doubts about what happens to those liver forms. So real quick about the management. Really what you need to do is confirm your diagnosis right away, and the way to do it is still plain old peripheral smear. A thin or thick preparation of blood smear remains a gold standard. It must be done within hours. There are tests that are available from the CDC, but you still want to know whether they have, how many parasites they have, because that's one of the criteria for severe malaria versus not. So only in remote locations where there's nobody to be able to read this, people resort to sending tests to the CDC, but we should not. The CDC discourages empiric treatment. We're supposed to get a diagnosis pretty quick and get the patient treated accordingly. If the patient is uncomplicated by the criteria we said and they are tolerating PO, you just use the same drugs we just showed. Treatment schemes are usually short. You must use a different drug than what you use in prophylaxis if they were taking it, of course. Severe falciparum malaria must be treated in the ICU and with IV combination therapy. I understand Dr. Burns had a case of this not so long ago, and they had cerebral malaria. So your options are here. We have a couple of comments on this. Quinidine is still available, but it's really hard to get, and it causes QT prolongation, so everybody's scared to use it. In recent years, artesunate has been made available exclusively by the CDC, and we need to call them to get it. That's how it works. It's not available elsewhere. It's not licensed by the FDA, yet the CDC can give it to you. Okay, moving on to dengue. The most rapidly spreading mosquito-borne disease in the world, period. And you can see the map here. This is, in 1960, there were a couple of spots there, and what happened after 1960? Big mess. So, quick snapshot on dengue. It's a virus, okay? So the causes, the Den virus, serotypes 1 through 4, and, so there's no vaccine for it, and you can get reinfected. Well, in this case, one virus infects you, you're immune against it, but you still have 3 that can infect you again. So that's why you don't really get immune to dengue, or you cannot reassure a patient that if they had dengue, they won't have it again. The main vector is this Aedes aegypti. There's also some transmission by Aedes albopictus. Very different from malaria. It bites you a day. Very different from malaria. It bites you in the city. Okay? So malaria, night, you're sleeping in the jungle, they bite you. Dengue, you are in your recliner in the beach or in the pool of a fancy hotel in the Dominican Republic. Higher risk, Caribbean and Southeast Asia. But as we showed, it's everywhere. And this shows you, let's focus on this number first. So there are 50 to 100 million infections per year. And we're not talking US, of course, worldwide. And apparently, this is terribly underreported, only 1 to 2% to the WHO, and this is what they are showing us in this slide. This shows you 2 things. Not only the total number of cases is increasing, but see here in this axis the number of countries that report dengue as the years go by. And so we're now hitting 70 countries that have it, and the US is not an exception. What has made this happen? There's one, the mosquito is a problem, okay, but man is also the problem. So the mosquito has some very interesting adaptation here. It has this desiccation-resistant eggs that conveniently can lay on a tire, okay? That's classic. Dengue, think of tires, and I'll tell you why. They can lay on a tire. Those tires can be traded internationally. Just add water, and you get a dengue in your country. This picture is everywhere. Like back in Lima, you see, the local public health department putting pictures of what not to do with tires, and this is exactly what you should not do, because this is asking for trouble. You're just adding water and reactivating these desiccated eggs that can hang in there for a while. And on top of that, you just add some viremic travelers from a different country. So you get the mosquito that is able to transmit the disease, you introduced it to your country, and then people with the disease come in with the virus in their blood, and then the mosquito just bites them and goes around and infects more people. So this is the result, as I was showing. These are the places you want to go to get dengue. The high transmission is in the Caribbean and Central America and Southeast Asia. Of most note, this is not something you get in sub-Saharan Africa, and just make that association. This is something you get in an urban place, not in a rural place like malaria. And again, daytime versus nighttime, right? Yep, those are the big places. So to put a name in, people who are not familiar with the map, India, Thailand, China, Indonesia, Philippines. So dengue in the United States. So you're going to see 2 numbers here. The first one is just plain dengue, and the other one is dengue hemorrhagic fever that has been renamed severe dengue. See how many we had in Iowa in 2010. We had at least 1 case that we know of last year that we took care of. You see, the state that has a little bit more than Iowa is Puerto Rico, or the territory. They have 10,000, and that's reflective of their location. New York City, again, a lot of imported cases, 141. But there's a great difference with malaria here. I mean, these are not just people who are traveling. These 2 states do have local transmission of dengue. So you can a couple of times, a couple of epidemics have been reported of 60-some, it's always under 100 patients that acquire dengue from other people living in that region. So it's there. So you can technically go to international travel to Florida or to Texas and get dengue there. That's a very important epidemiologic fact. So as I've been gathering, people are not very familiar with the syndrome, so let's go over it real quick. Please note that incubation period is generally much shorter than that of malaria. Think all these viral illnesses are always shorter in incubation than the parasitic one. So first, so 3 phases here, right? And we had I'm trying to correlate this with the patient we had, I think it was in November. She was a young lady who was doing missionary work in Vietnam, otherwise healthy, and returned, and she read the textbook because she had, I think, a couple of days of flu-like illness, high fever. She had this classic sign, pain. I mean, she referred to pain right behind the orbits. There we go. Okay, they're test driving the system, evidently. She complained of rash at the beginning, but that rash was actually more like a generalized flushing. I mean, she was all red, but you could tell, I mean, there were no spots of rash. She was all red from top to bottom. And she did have quite a bit of thrombocytopenia. So this is the stage that decides if you have severe dengue, formerly dengue hemorrhagic fever, or you just have dengue and you get better. And she took the turn for the good. So this is when the fever breaks, and when the fever breaks, you start having this phenomenon of increased capillary permeability. So you start third spacing, you start losing fluid from inside, losing plasma, you end up with pleural effusions, ascites, and you get in shock from that, from third spacing. This is very reflected in the hematocrit that goes up wildly. She had a little bit of hemoconcentration. She did not have any clinical manifestation of this, and so she did well. So we let her go before this, or actually at the beginning of this other phase. She said, well, I'm getting better, but now I have another rash. And that is the typical rash of dengue, which I'm afraid I did not take a picture of. But it consists of red skin with some islands of white. Very inconveniently, the IgG and IgM only start rising at that point. So there is no use at doing that kind of serologic testing. You just need to diagnose it clinically. What you want to do, you want to rule out malaria. Okay, never say, okay, dengue pandemic, Dr. Arbulu told me to think about it, and never do a peripheral smear. That would be the worst outcome of this talk. Practically speaking, there's no testing available for the reason I mentioned. I'm aware that the CDC dengue branch in Puerto Rico has a test that they can run in the early days before the IgG and IgM become detectable. I'm not recalling what type of a test it is. I presume it's a molecular test like a PCR, but don't take that to the bank. It is important to report the cases early while they are happening, and the CDC can give you further direction on that. There is no drug for this. We do supported management, and I would appreciate to be consulted to decide where we're putting this patient in the hospital and letting them go. There's no vaccine, so you gotta implement all these nice things that woman was doing in the picture before to prevent being bitten by the mosquito. And there is a nice publication by the WHO completely for free online. In the next, oops, who's this guy? His identity is protected by the shades. I'm showing this picture to make a strong point about this diagnosis. I mentioned the rickettsial disease in Africa that is second only to malaria as a cause of fever. That's Rickettsia africae, and the buzzword in any for test takers and in real life too is hunting big game in sub-Saharan Africa. So this gentleman is at risk for rickettsial disease. So that's That's not him, of course. Uh, um, the one thing you want to look that is not present 100%, and that can help and that can make the diagnosis is scar. So we said all these things before. Malaria, dengue can present with just fever, and dengue eventually you're going to get some flushing and some rash. But if you get a scar, you got it. It's African tick bite fever. This is caused by a rickettsia and is treated with doxycycline. Another rash you want to be acquainted with, another one of this unspecific illness that we mentioned before, is enteric fever or typhoid fever, and it occasionally gets these things called rose spots. So if you get this, you're lucky. Enteric fever does not overlap in time with dengue or malaria for the most part. It tends to be a little bit later, a couple of weeks later. In the next 3 minutes, and if people are enthusiastic, we can prolong this, talk about diarrhea. You want to know where to go to get diarrhea. If you want to make sure you get diarrhea, you go to Asia, not to Singapore or Japan. Singapore is among the 5 richest countries in the world now. And as you well know, diarrhea, traveler's diarrhea is associated with this kind of picture, unsanitary conditions in water and food preparation. So again, high risk, Asia except Singapore and Japan, Africa again, Mexico, Central and South America. And it was surprising to me when I reviewed this that most Caribbean islands are rather intermediate risk. Eastern Europe is intermediate risk, and South Africa is a different ballgame than the rest of Sub-Saharan Africa by virtue of being a more developed country. And the rest is kind of intuitive there. So attack rate of greater than 30%. So a third of these people are going to have problems thanks to these kits. It's important to recognize whereas most of our diarrhea here in the United States is viral and it will go away. Well, this diarrhea will eventually go away too, but it's mostly bacterial, because you just get an overload of those bacteria sitting on that water that the kids were playing with, or the food that is prepared in unsanitary conditions. So 80 to 90% is bacterial. A few of it is viral. Norovirus is big. Protozoa, and I'm going to just mention Giardia, which is the #1 cause of protozoal disease. So this green slice here. And finally, you got to consider food poisoning. So big time bacterial, and therefore antibiotics are useful. I don't want to bore you with this one, but it shows you that across the border, Mexico, Guatemala, India, E. coli in the form of enterotoxigenic E. coli is by far the #1 cause of travelers' diarrhea, only followed up by another E. coli, enteroaggregative E. coli, here in red. But by far, E-tech is up there. In order of significance, then, Campylobacter, Salmonella, and Shigella, which, unlike these E. colis, have the property or the possibility to go into invasive diarrhea. They actually penetrate your mucosa and can cause dysentery, a little bit of fever and bleeding. In recent years, there has been increasing recognition of these other 2 bugs that are still low, probably because they are not tested enough or they're not identified enough. Bottom line, E. coli, E. coli, E. coli, and these guys that can cause invasive diarrhea. This illustrates why it's generally no use of doing a stool culture, because all of you guys have E. coli in your stools, and we cannot differentiate that from this E. coli, say from some special testing that is not done routinely. So let me go back again. The testing of the stools would be directed towards finding Campylobacter, Salmonella, and Shigella in the appropriate clinical setting. This is mostly a benign illness. It will self-limit despite it being bacterial. However, it can be distressing for the patient. So let me point you towards this part. Untreated bacterial diarrhea, 3 to 5 days, not too bad. Viral diarrhea, 2 to 3 days. Protozoal diarrhea, then you're in trouble. It's weeks to months. The incubation period, again, you want to ask and get that story. So bacterial and viral kicks in within 2 days of exposure, whereas the protozoal one obviously presents, it's a different ballgame. It's chronic or late onset diarrhea if you wish. Don't want to overwhelm you with factoids, but this is an interesting one. Cyclospora cayetanensis, named after my medical school, proudly, in Peru. It's found in Peru and Nepal, and it is a parasite, but it actually mimics the time frame and the presentation of bacterial diarrhea. And it is treated with an antibiotic. It's treated with Bactrim, okay, which is actually not good for other types of diarrhea. And we'll show you that in 1 second, literally. You tell me when to stop. Okay, I think we're going to stop soon. Let me show you. I think some people wanted to hear or see this. These are the antibiotics that we can use for travelers-associated diarrhea, and you can see a couple of points only, and I'm going to be done here. Ciprofloxacin is still good for the most part, but don't give it to somebody who's going to Thailand because there is resistance to Cipro there. So now we use, for those people, azithromycin. That would be also your choice for pregnant people and children, which obviously cannot take Cipro. Do not treat these diarrheas with Bactrim or ampicillin. Bactrim, as I said, is for Cyclospora cayetanensis, and that's going to be like less than 1% of your diagnosis. I cannot overemphasize that the mainstay of treatment is not antibiotics, it's hydration. And hydration can be given for most mild cases with just broth, juice, and eating some salt crackers. You do not need to buy any particular or specific preparation. Well, we ran out of time. We can go over and over, but I'll be happy to take questions. Anybody recognizes this individual? Well, he gave me this, so he gave me permission. Yeah, so I cannot recommend this as a way to prevent diarrhea, but apparently it worked for Dr. Guffey. He was advised to do that locally, and he didn't get diarrhea by drinking water directly from that thing, whatever that is. Okay, so I can answer questions. I'm sorry for the time, but it's a lot to go over. Let me show some slides while people are still hanging around, and I won't speak. I'll just show them so they can probably generate some discussion as well.
That was an entertaining talk. I really appreciate you giving this today. I have one question. Do you see much babesia around here, and does that mimic malaria clinically?
And thanks for this. This feels like one of those superhero movies that they give you like the first part of the next one and at the end. So we're gonna do the local returning traveler. And this was originally meant to be one lecture, but as you see, it's not even fit for one lecture. So babesia, we don't see a lot of it, but it's in the New England area. It's endemic there. And that would be your differential diagnosis for malaria because the smear looks exactly the same, right? So, and you know that better than I do. So for people who don't know what Dr. Whitehurst is talking about is this parasite. I mean, we have our own malaria in the United States, quote unquote, which is babesia, which is endemic in the north, east of our country. And we're going to talk about that next time. Great, thank you. Imodium is good. That's the only other thing that I didn't say. Okay, Imodium is good for diarrhea. Thank you.